So I don't know if it's the plan this way that we're going to talk about money at the end of the day. So hopefully you guys got some sugar and some coffee and things like that. Because as you've heard for the last day and a half, this is not an easy topic, right? We are in a state in healthcare right now where we have never been. And a couple of people had referenced earlier that prior to the pandemic, healthcare was stable. I would argue that healthcare hasn't been stable for a long time. Right? I would argue that economically that we've been heading in this direction for a long time, and that the pandemic only accelerated what we already were experiencing and we already knew to be true. It just light years us away, right, from that stand as we currently look at it. But healthcare can't just be looked at in isolation, right? Your lives are not in isolation. We are not immune to the factors of the economy. We're not immune to the escalation of inflation. We're not immune to the manufacturers who work in a true supply and demand environment, right? We're all connected in one global world, and we're all connected together. And so that's what I'm going to talk about. We're going to start, we have our panel here, and they're going to start here in about 15 minutes after I set the stage. But what I wanted to set the stage for you today was kind of take you up a level. We've been talking about, margins and staffing and the cost of labor and all of those things. But what I want to take you up is to say, okay, what's going on in the global economy, and particularly the United States, that has a byproduct to healthcare? And then from there, how do we predict how we manage and we work within this global state? So what is our current economic outlook? Well, a couple of you have referenced today our GDP. Right? It is the best indicator of our producing goods in the United States. This is not healthcare, this is global, right? We've been climbing. This goes all the way back to the first quarter of 2013. You see the dip in the second and third quarter of 2020, but we've been climbing since then, right? So we are continuing as a nation and as an economic movement moving forward. But our rate of increase is slowing. Meaning that, people keep predicting recessions. You guys are watching your stock markets all the time, right? You're watching your 401k accounts. And we've been listening to all the pundits talk about how we're improving or maybe not improving. But the reality is that last year in 2021, we had a huge boost. Anybody know why? Come on, guys, you read the news, right? In 2021, what did the U.S. government do? Flood the market, right? They were giving subsidies to healthcare, they were giving subsidies to education, they were giving subsidies to everybody, and they flooded the market, and our GDP went up, right, from that standpoint. And we're starting to level down, but it is predicted, and these are predicted from the International Monetary Fund source, that our rate of increase is slowing, at least for the next 2 years. Right? So when we talk about what's the overall economy doing, yes, we are growing, yes, we are getting bigger, yes, we are producing more monetary. It's somewhat hyperinflated through inflation, but that rate of growth is slowing. The challenge has been in the last year to year and a half, as you guys know, this is inflation. You're experiencing it in your suppliers, you're experiencing it in your labor, you're experiencing it in your gas, your eggs, right, that you're buying at the grocery store. We're experiencing all of that inflation. And so this is the numbers going back and where inflation has been, and it's predicted to normalize in 2024 at around 2% from that standpoint. And I put the word maybe, right? The feds are doing everything they can do with increasing interest rates to get that inflation down to 2%. So we're maybe going to settle in on there from that standpoint. And so when you look at all of that, it has a huge impact on the labor supply. And fortunately or unfortunately, our labor, we're going to continue predicted to have low unemployment. Now again, this is global economy. So you can see this is the people working and the rate of unemployment. So the supply side of labor, if you're a hiring manager, if you own a business, if you're out there trying to staff a project, right, on the ground or anything else, it's only going to continue to be a challenge. Right? This doesn't help our compensation issues, right? It doesn't help our escalation of benefits. It only looks at to say that this is not going away anytime soon. We are going to be in an arms race for top talent for a long time from that standpoint. Okay, so that's the global economy. They gave me 15 minutes to do a lot, so I'm going to do it real fast. Right? I got to get the whole world in here in 15 minutes. So how does the overall healthcare fit into the economy, right? What does this have to do with us and why we're here today from that standpoint? All right, in 2021, remember that high rate of GDP, right? In 2021, we had the highest GDP in the world for healthcare, right? The highest. And you're not, for some reason, this is not populating. It's supposed to have lots of pretty colors. But what you're going to see is the United States, by far, had the highest percent of healthcare GDP in the world. We're at 17.89% in 2021. Our government the federal government, right, our state and federal governments or whatever, rank number 3 in the world for the most spending in healthcare, right? So we produce or have the highest cost essentially and the highest GDP in the world in healthcare. Our government is third, only surpassed by Costa Rica, right? They ranked in 2020, they were number 1. But even during the pandemic, we were still very much spending a ton of money at the government in healthcare. And you, me, everybody around us, we spend the most money in healthcare in the world. And somebody mentioned this earlier, you took my thunder, right? At 12, on average, about $12,000 a year per person in the United States is spent on healthcare dollars, right? We are by far the most expensive. We have by far the most spend at the governmental level, which is, by the way, coming through your taxes, right? That's no joke from that standpoint. And out of our pockets, we are spending the most in healthcare in general. So even without inflation, and you look at what's happening on the economy side, we're continuing to project to increase our spend in healthcare, right? From that standpoint, from 2019 to 2050, right? So essentially 25, 26, 27 years from now, right? We'll have increased our spending by about 38%. Now, anybody have a clue as to why we are going to have so much more spending in healthcare? Oh, excellent. Awesome. Absolutely right. So much of healthcare is dependent on demographic profiling, right? Demographic aging, the chronic diseases that come along with everything we've been talking about for the last day and a half, but we are going to keep spending money in healthcare. So what does this mean for legacy providers? So legacy providers, as we define it, are your traditional healthcare providers, right? Your hospital systems, your physicians, your nursing, post-acute nursing facilities, people who have been doing healthcare for a long time. I am not talking about Optum. I am not talking about Humana, and I'm not talking about those who are trying to disrupt the healthcare system. I'm just talking about those that are caring for it right now, which is a vast majority of both the employed and who we go see in general. So what does this mean, right? We've got lots of spending happening. We've got inflation that's hopefully going to level out around 2%. But what this means in general is that we're reducing access to traditional inpatient care. So this is the number of beds, hospital beds in the United States since 1975, okay? And it has bubbled up a little bit, and it's going to start coming down. Now, this doesn't take into account the last 2 years, right, 21, 22. We don't have that in the data set yet from that standpoint, but access is being limited, and we know that. We know that we're closing units. We know that we're closing emergency rooms. We know we're having problems staffing them. All of those things, but access is slowly being limited from that standpoint. The flip side of that is that if you're a community hospital and you're less than 200 beds, you're real rocky right now, right? Your financials economically are really, really hard because you don't have scale. But unfortunately, when I talk about access, look who has the most access points in the United States by hospital size, right? Your academic medical centers, there's only 327 hospitals that have more than 500 beds, right? And a lot of your business development plans are targeting those guys, right? Because they're the ones who have money or have scale to be able to get to it. But your community hospitals are the ones who are on a life string sitting out in rural America or in small towns or in middle-sized towns who are trying to make it work. And so as we look at the economic profile of what we talked about for the last day and a half, the challenge is that they are the most at risk, but they also have the most access points for a majority of the population. Right? So when we talk about access, it's not just the closing of units or the non-staffing of them or closing of emergency rooms or closing hospitals, right? It's where they're located. And in New York, if a hospital closes, I'm sure a couple of them will pick up the slack, right? They may have some problems and it won't be a problem. But if you're in rural Alabama, right, and your hospital closes, guess what happens to that town? It's done, right? Without a hospital, you're not going to have people live there. They're going to move to where they can access care. So this becomes a real problem as it relates to access. Now the number, and I just literally, this is real-time information. I pulled this dashboard right before we got here, but the number of rural hospital closures are accelerating. So you can see down at the bottom from 2005 to 2023, and these are the number of rural hospitals that are closing every year. Guys, they're not shifting down to FQHCs. They're not becoming primary care hubs. They're not just operating in urgent care. They're shutting their doors and they're saying bye. Right? And the communities are picking up the slack of this because all the things that we've talked about economically, it's accelerating. And while this is happening, the cost curve isn't bending, right? This isn't a normal supply and demand where the demand goes down, right? Because the demand goes up and the supply goes up, all those economic things that we talk about in our courses, what we've seen is a continual healthcare expenditure in this country and hospitals raising their prices to pass along what they are already incurring. And you've heard all the reasons why they're incurring that, right? It's labor, it's all the things that we've talked about. We won't keep going there. But as the number of beds decline and as utilization of inpatient declines, their pricing is going up to cover the fixed cost, to cover the 365 24/7 coverage, to cover your subsidies when you go to the ED and you need a cardiac consult there in the emergency room and it's 2 a.m. in the morning and everybody's sleeping and you're waking someone up, right? It's to cover all of those things that are happening. So even though we've had declining utilization on the inpatient side, going to ambulatory, and we've had declining beds, we're continuing to see our costs rise for all the reasons. And what does that mean? Well, some of that cost, as we talked about earlier, is around labor. But this was an interesting statistic that I looked at, that hospitals, this is the number of people employed since 2000, right, over the last 22 years by hospitals, in the thousands from that standpoint. And these are in thousands, right, millions, clearly. But we've increased the number of people in our hospitals by 41%. Right, in that same time period, in 22 years. So we are not, we're not just, it's not small, right? Some of that cost is loaded into the labor market, but we're also employing a lot more people to do a lot more things, right? Think of your IT departments. 15, 20 years ago, would they have been a couple hundred people? No, we were doing everything by paper and by fax, right? We didn't have a couple hundred people in there, right? Case managers. We didn't have tons and tons of case managers to manage care and the complexity of our system 15, 20 years ago that we do right now. So a lot more people are entering the system to manage the complexity than there were years ago. And that's only supposed to increase. So this is where your demographics come in, right? So healthcare is a lot of people doing it. So the demand for healthcare employment between now and 2031 is supposed to be dominant. And I say dominant, look at that, that's in the thousands, right? We are eclipsing every other industry in our need to employ people. From that standpoint. Below the line that you see are industries that are negative. I pointed with one with a little arrow, you see it, right? Yeah, what's that little arrow look like, right? That's the federal government. They're projected to decrease in the number of people that they are employing in 10 or less than 10 years from now, from that standpoint, right? Because they're shifting into the private sector and because they're looking at their tax returns and increasing costs and their ability to continue that on a population. From that standpoint. So this is just a telling sign of where some of the boluses are coming and how the costs are being structured moving forward. So what does this mean for us as patients, right? We're going to get to the industry in a minute, but for you and I, we're patients every day, right? We have grandparents, we have parents, aging parents, we have children, etc. Well, unfortunately, we're just going to keep paying more, right? And that is because, as you heard from the providers already, they have nowhere else to pass along those costs and they cannot keep absorbing them. Right? This doesn't work in an economic model, right? You will go under. You will no longer exist. You'll be in the place of the rural hospitals who have been doing charity care and Medicaid and unemployment and all of those things for such a long time that they can no longer survive under the weight of that pressure. So we're just going to keep passing those costs along. This is 2022. Hospital services, this is the inflation rate, right? In that year. Nursing home, outpatient services, prescription drugs, and physicians. So last year, this is the inflationary rate by category of where we're seeing the costs being allocated to. All right, so what does that mean for us patients? Unfortunately, this is the crippling slide. This is medical debt, right? And I thought for a long, long time that the number one reason why people went into bankruptcy was because of medical debt. And then I actually went out and researched it and saw that it's not. You guys want to take a guess at the number one reason why people go into medical debt? We talked about it here a ton. Education, loans, by far the number one reason why people declare personal bankruptcy in America, right? Medical debt's number 3, by the way, from that standpoint. But you can see that the uninsured, ages 18 to 64, guys, those are your working class, right? That's not your old, that's not your babies. These are people who have graduated high school who should be productive members of society, but they're uninsured, a lot of them by choice, by the way, due to premiums. 62% over there has healthcare debt right now. Not loans, not car insurance, not overpriced mortgages, not high interest rates. They have medical debt in that working age group right now that they cannot pay, right? So all of this is being passed along. At some point, this is going to be a big, big problem, right, as we move forward. All right, so the tale of two systems. You guys familiar with the classic, The Tale of Two Cities? Yes. Right? From that standpoint, so I'm going to give you a little existence. We talked a lot about today, and they kind of teed me up a little bit to talk about how we have an economic capitalistic model, right, that's based on supply and demand, just like most of your companies and who you work for. And then we have government, regulatory, and all the compliance issues that come there. Those are the two systems. And right now we're trying to smash them together and figure out a balance on how it works. Is it working for us? I would tell you no, it's not. And I'll give you an example. For the last several years, if you are Walmart, or if you're Amazon, or if you are CVS, how did you get to the power you have in the market right now? Somebody want to guess?
E-commerce.
E-commerce, okay, that's a good one. But it underscores scale. You got to scale. If you're in Walmart, you're in every local market, right? And you've got e-commerce. If you're Amazon, you are global, right? You got to be able to do low price. Remember Walmart's theory? Low price, high volume. Well, hospitals have the same thing. They have high volume and they're trying to get to low price. And so they are desperately trying to get to scale, which is why over the last 3 to 5 years we've had significant amount of mergers and acquisitions, right? They're all getting, and they're jumping across states to do it, right? They're jumping across geographical regions to get to scale so that they can survive. Well, this quarter right now, it's in the headlines of your Becker's Healthcare, if you guys want to look at it, over the last 2 days. But we have the slowest rate of M&A currently right now than we've had in the last 3 years. Why? Economics are not any better. The current conditions are getting worse, so why are we slowing up in our attempts to get to scale? Somebody want to answer?
Cost to borrow. Tight capital.
Cost to borrow? Yeah, that's a little bit of it, right? I will tell you the majority of it's political. The FTC and your state legislatures are coming down on all of these. So Stanford and Fairview, they just split up, right? One after another of these deals are being intersected through politics to say, look, we don't really want you to get to power. We don't want you to get to scale because at some point you are too big to fail, right? You're too big to fail. And so we don't want to be in a position as the federal government to bail you out. So we're going to make sure that there's competition, that there's price transparency, and we're going to start to break up these conglomerates. And so we don't want you to vertically integrate, particularly in a geographic region, but we might be okay if you jump across a couple of states and you do it that way, right? So we're seeing really the smashing of together of trying to limit the amount of scale, essentially, for sustainability through politics and trying to make sure that we have access and equality and everything else in healthcare from that standpoint. But this is the tale of two cities, right? It's two healthcare systems that are trying to merge together and trying to look at things the same way, and they are vastly, vastly incentivized differently, right, from that standpoint. All right, so I'm going to ask a really polarizing question. Nobody shoot me, okay? From that standpoint, how many of you believe that healthcare is a basic human right and should be free? Basic human right and should be free, which means you walk into the emergency room and they have to give you care, whether you have the ability to afford to it or not. That's what I'm talking about. It's a basic right, right? You're right. How many of you guys believe that the level of your care should be based on your ability to pay and or reimburse for that care? You do it in airlines. You get first class when you pay for it. You do it in hotels. You get suites, penthouses when you pay for it. Right? You do it in every other industry. If you pay more, you get better of something, right? How many of you believe healthcare should be the same way? Not many of you. Well, public polling is 50-50. Okay, so half of the country believes that it is a basic human right and should be free and provided for regardless of your monetary ability to pay. And the other half of our country says, I don't want to pay for their care. How many of you guys have talked about that, right? I don't want to pay for the kid who gets on a motorcycle, does 90 miles an hour down the interstate, has an accident, ends up in the ED and has no insurance because he's 21. I don't want to subsidize that, right? This is the polarization happening in healthcare, which will only prolong our tale of two cities, right? And our two care delivery systems, because we are trying to rectify both of those, both a capitalistic mentality and a culture, right? And a basic human right survival moral issue. All right, that's it. You guys ready for the panel? Let's do it.